Hello and welcome to Prairie Pulse. Coming up a little bit later in the show, we'll hear from singer-songwriter Rachel Iannarone. But first, joining me now is Mary Wakefield. Mary, thanks for joining us today.
It's a pleasure to be here.
Well, as we get started, we often say, I didn't give you a title or anything because there's so much to talk about. Tell us a little bit about yourself and your background, maybe where you're originally from.
Sure. So I'm a Devil's Lake native and born and raised there, and actually developed my first interest in healthcare, which was the start of a long career in healthcare, right in Devil's Lake at the local hospital. So that's where I'm from.
Mm-hmm. Well, with that said, you're here for many reasons I talked about, but you recently got an award from the American Academy of Nursing, and it was as a living legend. How did that come about?
Well, thank you for mentioning that. The American Academy of Nursing is a national nursing organization, and it is comprised of nurses from across the U.S. who are pretty accomplished. They are hospital administrators, top flight researchers, nurse educators, wonderful nurse clinicians that comprise the membership of that organization. And they make recommendations every year to name one or more individuals a living legend. And so that's the particular award. It's rather nice because it's from peers, it's from fellow nurses, and that makes it especially nice. So that's what the award is. And it's probably the top award in nursing that you can receive. So a nurse from Devil's Lake, North Dakota, that's a pretty nice award to receive.
It's nice for anybody, but especially that you were able to get that, because people should know, but there are people out there that won't know. Yeah, but talk about your time as being a nurse and working in acute care facilities.
Sure. So as I mentioned, I got my start working as a nurse's aide, actually, in a local nursing home and in the local hospital in Devil's Lake when I was still in high school. And it was a really important time for me because I saw healthcare providers in that small rural community in North Dakota who were unbelievably caring, accomplished, smart, really connecting with the people in that community in an impressive way. It was really impressive for a 16-year-old to observe, that's for sure. And I saw them make such a difference in people's lives in terms of providing top-flight quality care. It wasn't because there was a lot of equipment, there wasn't a lot of technology back in those days when I was 16, but it was because those nurses, pharmacists, doctors cared deeply about the individuals who lived in their community. And that passion for caring for others really came through to me. That's what whetted my appetite for a career in healthcare. And I was particularly dazzled by the nurses in that small hospital. I worked in the newborn nursery, and I worked on medical surgical floors in that hospital, and that was the kickoff to a very long career.
Well, we want to find out more about that career, but how rewarding was it for you to have a career such as this?
Really exciting when you know that what you're doing every day is making a difference, some days small differences, some days bigger differences, in the health of individuals and their families, that if you provide the most exceptional care you can, that makes a big difference to people. And so if I had any reservation, it was only that there might have been insufficient time to do even more for the people for whom I cared. It's a pretty exciting career, I have to say.
Mm-hmm. With that said, can you go a little more in depth and tell us about your career sort of in that rural healthcare in North Dakota?
Yeah, so in addition to working in that hospital at the very start of my career, I also was a faculty member many years ago for the College of Nursing at the University of North Dakota. And in that capacity, I would travel to small rural towns to check on our senior nursing students that were working in those small rural hospitals. I would always have an opportunity to meet with the chief nurse executive, to meet with some of the other staff, and of course to meet with the student. Those were wonderful opportunities, both for me to see how care was delivered in different small hospitals across the state, but also to see how the staff of those rural hospitals really wrapped themselves around that nursing student, making him or her feel really valued in that community, and oftentimes offering them a position even before they left, so that once they graduated, they would, if they're really good, would have offers of jobs later. So that was an opportunity to see the landscape of North Dakota in a very different way as a faculty member. And then, as I said, to also see healthcare providers in rural communities really making a difference. A lot of times in our small towns, as you know, it's only a handful of nurses in many of them, maybe a couple of physicians, one pharmacist or so, and so on. So every single one of those providers makes a big difference to access to quality care for those small rural communities in our state.
Now, you've worn many hats and you wear many hats. Can you tell me a little bit about what your relationship is with Austin and Georgetown and UND right now?
Sure. So I'm an adjunct faculty member at the University of North Dakota in the College of Nursing. And so if they ask me to come and help teach a course as a volunteer, I do that. I also sit on an advisory board to a grant that the School of Medicine has to further study cancer in the region, not just in the state. So I'm on that advisory board. For Georgetown and for the University of Texas at Austin, I'm a part-time visiting professor at both of those universities. And in most of those locations, I'm either bringing my rural health background, my nursing background, and or my background in health policy.
Okay. Well, let's talk about some of the challenges you faced in different times. When you were directing the Rural Assistance Center, what kind of challenges did you have then?
So the Rural Assistance Center is an information repository that's based in the Center for Rural Health at the University of North Dakota School of Medicine and Health Sciences. I was the director of the Center for Rural Health for about 7 years, and one of our major projects, federally funded projects, was this entity that we stood up and still operates today, though I have nothing to do with it other than I use its resources like everybody can if you have access to the internet. It was to stand up an information resource on rural health care, all facets of rural health care across the United States. It's a one-stop shop, if you will, that the federal government supports and that North Dakota provides through the Center for Rural Health as a resource on access to grant programs for medical students, for example, to better understanding some of the big challenges facing rural hospitals across the United States, to going to that resource for the latest data on individual states and their health status of their rural populations. So it's a big repository. It's been in place now at UND. I know it's gotten even bigger and better in the time that I've been away, but I was there when we first started it. And it's really an exceptional resource to the nation, not just to North Dakota or not just to UND, but actually a resource to the nation on all things rural health. That's pretty exciting. And what caught my attention in terms of applying for it many years ago now for that grant was the strong belief that the best experts on rural health, of course, are in rural parts of the United States. And with the advent of technology, the internet, et cetera, we could provide expertise really from any rural place almost across the nation. And no place better than North Dakota if you're looking for rural health or for technology applications. Okay.
What were some of the other positions you held at UND?
I was a professor at the College of Nursing at UND. That was my very first job at UND. And then later on, the director of the Center for Rural Health and also the Associate Dean for Rural Health at the School of Medicine and Health Sciences.
Mm-hmm. How have you seen rural health care change over the years, especially with the focus on getting doctors in underserved areas?
That has been a chronic challenge, a challenge of attracting physicians and, frankly, other providers, too, into rural areas. So that's not new. It's been an ongoing challenge. There are different strategies that the federal government and state governments use to try and entice individuals to come and practice in rural areas. But one of my big concerns is that our average age of physicians, for example, working in rural communities is older than in our urban communities. So this leading edge of retirement among physicians is actually leading out of our rural communities where we're already pretty thinly staffed. As a result, some of the new efforts that the federal government has been engaging to help support physicians, nurses, and others to practice in rural communities becomes extremely important, and states stepping up to help make that connection to get clinicians into rural areas is also very important. But we've got new tools today that we didn't have when I started my practice. Back, I hate to say it, but back in the late 1970s, new tools like telehealth technology that can connect a physician in an urban area with a nurse practitioner in a rural area, or that can connect a specialist in an urban area with a family practice physician in a rural area if they need some additional backup. That has made a huge difference in getting additional services out to rural communities. So practice as I practiced it when I first started looks quite different than the way healthcare is practiced in rural communities today. And in many respects, that's a good thing.
Well, Mary, obviously you've been in the nursing field, you've taught at colleges, but you've also worked in administrations. And can you talk a little bit about your time in the Obama administration as you were the, I believe, acting Deputy Secretary for Health and Human Services?
Sure. That was actually pretty exciting for me for a lot of reasons, but not the least because President Obama appointed the first nurse. I was the first nurse in two key positions in the U.S. Department of Health and Human Services. The first nurse that had ever been appointed to those particular positions, the one that you mentioned, the acting deputy secretary for the U.S. Department of Health and Human Services, which is the second seat in that agency. It's a really big agency. It has about 80,000 employees all over the world. Most of them, of course, in the United States, but not just. And then one of the other positions at the U.S. Department of Health and Human Services, also the Health Resources and Services Administration. That's the position I came into first and was appointed by the president to. Served in that for 6 years. Frankly, I was getting really tired and thought, well, I need to come back home to North Dakota. But then all of a sudden, whoops, there was a vacancy in the deputy secretary position. So I was asked to serve in that, and I finished out those entire 8 years of President Obama's tenure. So really exciting for a nurse to be in those positions. And I think personally, because I always started with a nurse's perspective, and that is on any program or policy that we might be advancing, how does it impact a patient? How does it impact a family? How does it impact a community? That's a nurse's perspective, and that's what I brought to those positions. I thought that was pretty important, and I still do, rather than leading with any other consideration. It was always about how will this impact rural folks back in North Dakota or in Nashville, Tennessee, or in other parts of the country.
Yeah. So what exactly were your responsibilities, and kind of add these together, and what were your greatest achievements when you worked for the Obama administration?
In the first 6 years, I was responsible for about 90 different programs. The Federal Office of Rural Health Policy, which has a complement of rural health programs, grant opportunities that are located in the Health Resources and Services Administration. Among those 80 programs, it also included the Organ Procurement and Transplant Program that the federal government operates, all the way to the Maternal Child Health Bureau, which puts money into every single state, including North Dakota, to strengthen mothers' health and the health of infants and small children, and an array of other programs as well. So those are just a few examples of some of those programs for which I had responsibility. But some of what I'm pretty excited about that I was involved with when I was there was really pushing out the boundaries of being able to put more physicians, more nurse practitioners, more psychologists, more dentists into rural and urban underserved areas. The Obama administration markedly expanded the National Health Service Corps program, and that program is specifically for placing more clinicians into rural, as I said, and urban areas that need them the most. In addition, I was also responsible for overseeing a big expansion in primary care in the United States. That's been one of the areas where the U.S. could historically be doing better than we have been. That is ensuring that people stay healthy, that they get healthy, and that we have adequate numbers of primary care physicians, nurse practitioners, and others to deliver preventive health services, to make sure people have their screenings, their immunizations, and so on. Well, we markedly expanded community health centers across the U.S. In my tenure there, we were serving about 19 million Americans through community health centers in every state in the country, from Fargo, North Dakota, to other parts of North Dakota all over the United States. So about 19 million total people getting their care in community health centers. Today, we have about 27 million Americans who are able to get primary health care, the health care to manage their high blood pressure, to manage their diabetes, bricks and mortar infrastructure that's been significantly expanded. That's really important to focus on keeping people healthy in the first place. When I worked as a nurse, I practiced in intensive care. In intensive care, you're taking care of people, of course, who are incredibly ill. Some of the people that I cared for, I found out pretty quickly and pretty clearly, would never have needed to be there getting that very intense care, would never have been that ill had they received care and management of their high blood pressure, of their diabetes, et cetera, on the front end. That's a lot of primary care, and access to primary care, critically important. We expanded that markedly in the Obama administration. I'm pleased to say that's still happening today.
That's great. But let's back up. Even years before that, you actually worked for Senator Quentin Burdick.
I did, a
What was
U.S.
your role
senator.
there? Yeah.
So he hired me first as his health legislative assistant. It's the reason that I left the University of North Dakota the first time. I left the College of Nursing because he'd offered me a position as his health legislative assistant. There aren't very many nurses who work on Capitol Hill, and I was frequently asked, well, you're a nurse, what are you doing here? And my answer was always, it's because I'm a nurse that I'm here. The federal government has a big footprint in health and health care. And so it's a good thing to have people who know a little bit about healthcare, I think, to be involved in managing some of those and helping not to manage, but to inform some of those policies. So for him, I started as a health legislative assistant. When he was reelected to his last term, he asked me to be his chief of staff, and I served in that capacity.
Yeah, and then you went on to work for Senator Conrad.
I did, for Kent Conrad, Senator Conrad as well. He'd asked me to come back and work for him as his chief of staff. And in those positions, I always had a hand in healthcare in both of those offices because, frankly, that's been my first love.
Sure. Did you ever miss nursing while you were doing all these other things?
Yes. When I lived in Washington, D.C. the first time, the apartment that I had was right across the street from a hospital. And when I would come home late at night, because these were long days working for Senator Burdick and long days working for Senator Conrad, because they were there too, working long days, long hours. But when I'd come home in the evening, sometimes I could see across from my apartment into those patient care rooms before the curtains were drawn for the evening. And I'd see nurses, of course, walking in and out of those rooms. And I think, gosh, that'd be really nice to be there too. But the difference for me was working as a critical care nurse, for example, you're caring for maybe 2 patients at a time. If you're informing health policy, the policies you're informing may impact 20 million people. And so nursing in both of those venues, incredibly important. And I'm privileged to have been able to serve in each.
Mm-hmm. Well, you also worked on the global program on AIDS at the World Health Organization, WHO. Can you talk about that for just a moment?
Yeah, that was an exciting career opportunity. I worked as a consultant in Geneva, Switzerland, and to tell you the truth, that was at about the time when HIV and AIDS were becoming a global, a very significant global problem, particularly in different parts of the world. Africa, sub-Saharan Africa, the United States, and we were right on the precipice of seeing a big uptick in numbers of individuals infected with that virus in India as well. So to work on a global that program, global program on AIDS, was to come to a healthcare set of challenges for which therapeutic interventions, drugs, et cetera, were not available. It was all about prevention of spread of that disease at that time. So it was a really tense point in time because thousands of people were being impacted, scores of thousands infected by that disease, not just in one location, but in many locations. And that's always a problem with infectious diseases, particularly those that don't have vaccinations or effective drug treatments. So this was all about trying to contain that spread at that time.
Mm-hmm. Well, let's turn back to the University of North Dakota. Can you talk about what the School of Medicine at the University of North Dakota means to North Dakota?
Well, it's really exciting to watch now. Again, from a distance, I was there for 7 years, but from a distance, what's exciting is certainly their research portfolio, the work that they're doing in health-related research, and also their very intentional production of physicians that can practice in and will practice in rural areas. Obviously, we need them in urban areas in the state of North Dakota and the region as well. But they're very deliberate about trying to put more physicians and other healthcare providers, physical therapists, medical technologists, and others into rural areas. And they're pretty successful at that when you look at the University of North Dakota School of Medicine compared to schools of medicine elsewhere across the United States. That's important to North Dakota and very important to our rural communities.
So what's next for you?
Well, what's next is a lot of what I'm doing right now, and that's teaching. I'm trying to share a little bit of what I've learned in my career with that next generation of nursing students, hospital administration students, health policy students in those different universities that I'm involved with. That's pretty exciting to see that next generation of healthcare professionals that will be practicing in a world that's so dynamic, in healthcare that's changing so rapidly. That those changes are outpacing a lot of even what those students are being taught right now. So much of our focus is really has to be on ways of thinking and anticipating problems that are likely to emerge in the future, and rather than focusing just on what's in front of those students today or those problems that we're facing in the country today in terms of healthcare. So working with students is a big part of what I'm excited to do. Then I'm also involved in some foundations, not-for-profit foundations, that focus on medical and nurses training nationally. And I'm involved with some health systems, state of Washington and other places too. Doing a little work on health policy in Washington, D.C. as well.
Mary, with your career, it's no wonder you received that award from the American Academy of Nursing as a living legend. Thanks so much for joining us today.
Pleasure to be here. Thank you.
Stay tuned for more. Rachel Ironarrow is a fresh talent who brings a youthful sense of love, optimism, and fun to her original tunes. She is sure to gain a strong fan base as she tours the region with acoustic guitar in hand.
Tell me to wait for you. I tell you no way. Don't say I ain't right for you, 'cause I know you ain't right for me. And just like a cigarette cries in the dead of the night, I'll be your worst regret, but hey, at least I'm on your mind. Singing that song, walking down the street, got your hands in your pockets and your eyes on me. I got you right where I want you to be. Oh, how I wish, but it'll never work. My sense of direction tends to take wrong turns, but don't you go run away. Well, I know you ain't right for me, it's true, but I think I could be the best bad thing for you. So rather than playing it by the rules, I think I could think of something better to do. You think I could be the best bad thing for you. Well, I got a gypsy soul, I ain't made to stay, but I'll keep you holding on, then I'll hit you like a hurricane. See, I ain't the type of girl that's trying to settle you down. I'm here for a good time, so what do you say for now? Keep singing that song, driving fast with me, while the blue lights chase us down a dead-end street. I got you right where you don't want to be. Oh, how I wish, but it'll never work. I just can't seem to keep my feet in the dirt, but don't you go running away. Well, I know you ain't right for me, it's true, but I think I could be the best bad thing for you. So rather than playing it by the rules, I think I could think of something better to do. You think I could be the best bad thing. And I'm not trying to be what you need, just what you think that you need, boy. Yeah, I wanna be the one bad mistake, kinda glad that you made, boy. When you're humming that song, sitting in the bar with your hand on the bottle and my name on your arm. I'm long gone, but I'm never that far. I know you ain't right for me, it's true, best bad thing for you. So rather than playing it by the rules, I think I could think of something better to do. You think I could be the best bad thing for you. Oh, 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 for you. Oh, oh, oh. Tell me to wait for you. No. Hey.
Well, that's all we have on Prairie Pulse this week. And as always, thanks for watching.
Funded by the Minnesota Arts and Cultural Heritage Fund with money from the vote of the people of Minnesota on November 4, 2008. And by the members of Prairie Public.